Okay, so I'm 100% sure you have a friend who comes to your room, wastes your time, and when he's leaving your room, he don't close the door. Same happen with aortic regurgitation. The aortic wall does not close properly and blood came from aorta into the left ventricle. So this is our topic, aortic regurgitation. So it says that aortic wall damages due to any cause and blood returns from aorta into the left ventricle. Now comes its pathophysiology. Due to any degenerative cause, that may be degeneration of this wall, like this wall is damaged due to any cause like rheumatic heart disease, infective endocarditis, etc., or abrupt impairment, like sudden changes in this wall happen and this wall is damaged. Due to this cause, blood leak back into the left ventricle. Blood came from aorta into the left ventricle and decrease aortic diastolic pressure. Normally in when there is diastole, this wall close and blood does not come normally. So here the pressure is aortic diastolic pressure is normal. Suppose it is 80, but in this case the blood came here and the pressure it inserting into the walls, it decreases, like you can say 60 or something, and left ventricular and diastolic volume is increased. Why? Because during diastole, blood came from left atrium into the left ventricle, plus this blood that is regurgitating also came into the left ventricle. So left ventricular and diastolic volume is increased. Degeneration or abrupt impairment causes leakage of the blood from aorta into the left ventricle, decrease aortic diastolic pressure and increase left ventricular diastolic volume. So in chronic aortic regurgitation, there is volume overload. So when this happen for years and years, so there is volume overload, continuous, there is more volume in left ventricle. This causes eccentric hypertrophy. So hypertrophy, this eccentric is actually hypertrophies of two type. The one is concentric hypertrophy and second one is eccentric. In concentric, suppose this is left ventricle, its muscle mass is increased, like this one. But in eccentric hypertrophy, normally the size is increased but muscle mass is decreased, like this one. The volume is increased of left ventricle. Okay, and there is left ventricular dysfunction. So left ventricular don't work and ultimately lead to the heart failure. This is its pathophysiology. Now come to the etiologies. What are the causes of aortic regurgitation? So in case of, we have divided into either it is chronic aortic regurgitation or it is acute aortic regurgitation. In chronic aortic regurgitation, the number one cause is congenital bicuspid aortic wall. So what is this congenital mean? By birth, bicuspid aortic wall. Normally the aortic wall is like this one. It has three cusps. This is one cusp, this is second cusp, and this is third cusp. But in congenital bicuspid aortic wall, the one wall is not fused into other. So there is totally two wall, one in this one and second this one. So there is more pressure on this wall which can lead to the aortic regurgitation. But it's the number one cause in developed countries. Okay, in developed countries, not in developing countries like America, USA, Europe, etc. The number one cause of aortic regurgitation in these countries is congenital bicuspid aortic wall. Normally this congenital bicuspid aortic wall causes aortic stenosis, but it can cause aortic regurgitation, and symptom appear as early as 30. Normally due to any other cause like rheumatic heart disease, the symptom of aortic regurgitation occurs after fourth decades, like in 40s or in 50s, but this can happen as early like in 30s. So the second cause of aortic regurgitation is rheumatic heart disease. In rheumatic heart disease, body produce autoantibodies that attack the heart itself. Specifically in aortic regurgitation, it attack the aortic wall, this one, and causes this degeneration and all lead to the whole pathophysiology. It is most common in developing countries like Pakistan, India, Latin America, Africa. These countries, the number one cause is rheumatic heart disease. The other cause could be infective endocarditis. In infective endocarditis, due to any cause like bacteria, Shigteria, it form in vegetation, it can also form in aortic wall and cause its regurgitation. Another cause is rheumatological condition like rheumatic arthritis, systemic lupus erythematosus. In these condition, the autoantibody produced, and these autoantibody again attack this one aortic wall. And the other cause is genetic syndromes like that causes aortic root dilatation. Suppose this is aorta, है ना? Suppose this is heart, left ventricle, and this is aorta coming out of left ventricle, and this is mitral valve. This is aortic wall. So there is dilatation of this root, aortic root. Aorta come from this to this one. It is dilated, है ना? So which normal condition cause aortic root dilatation? That or Marfan syndrome, Ehlers-Danlos syndrome, and familial thoracic aortic aneurysm. These condition, these syndrome can cause aortic root dilatation, and which ultimately leads to the aortic regurgitation. Now the cause of acute aortic regurgitation, the number one cause is aortic dissection, infective endocarditis, specifically due to the Staphylococcus aureus bacteria. This causes very rapid attack on aortic wall. So there is rapid degeneration and ultimately aortic regurgitation. As well as the third, failed repair of aortic stenosis. Suppose a person is having aortic stenosis, so he do the surgery and surgery is failed, that ultimately leads to the acute aortic regurgitation. Now comes to the pathology. So on histopathology, when you see on a microscope, you will find post-inflammatory valvular damage. There is valvular damage and post-inflammatory, like after inflammation. So after inflammation, what you find, we know that is there is collagen deposition plus fibrosis. So when you see this wall under microscope in histopathology, you will find collagen deposition and fibrosis. In case of aortic dilatation, like in case of these syndrome, that ultimately lead to the aortic regurgitation. So in aortic root dilatation, the wall is normal because the root is dilated. This aortic root is dilated, but the wall is normal like this one. Normally it was this, and now it's only normal. What happened? This root is dilated. So the pathology in thoracic aortic aneurysm, cystic medial degeneration or necrosis. You will find on histopathology cystic medial degeneration or necrosis. Now we'll come to the clinical presentation, how patient will present to you in clinic. In chronic aortic regurgitation or in acute aortic regurgitation. In chronic, mostly the patient remain asymptomatic for years and years, like you can say for 20 years or for 2 decades. After that, symptom appear, and symptom of heart failure. We know that in pathophysiology we have studied ultimately lead to the heart failure. So the symptom is would also be of heart failure. These symptoms are exertional dyspnea. It is the first symptom that appear. Like patient will have a difficulty in breathing when he do some sort of exercise, like he walks on stair, he do running. So he feel exertional dyspnea, he feel shortness of breath. Also orthopnea. Orthopnea mean when he lie down, he lie and he will feel shortness of breath. P&D, paroxysmal nocturnal dyspnea. At night time when he was sleeping, he suddenly feels shortness of breath. This is paroxysmal nocturnal dyspnea. And angina, specifically in night, and decreased diastolic pressure. And in case of acute regurgitation, there is decompensated heart failure plus cardiogenic shock. In cardiogenic shock, there is tachypnea, blood pressure would be decreased, and there could also be pulmonary edema. Simply this heart failure, normal blood is coming from aorta into the left ventricle. Here is accumulation of blood, ultimately lead to the heart failure. Left ventricle cannot pump the blood, and when it did not pump the blood into the body, all these symptoms will appear simply. In physical examination, it's very important thing. The most important thing of aortic regurgitation is its physical examination. You will find decrescendo diastolic murmur. Murmur means there is sound when you put on your stethoscope and auscultate your chest. You will find a murmur, a sound on diastole, not on systole. You will find on diastole, and that is decrescendo. It is a specific sound. In case of valvular aortic regurgitation, mean if wall is damaged. So then you will find on left mid-sternal border, and if there is aortic root dilatation, you will find on right upper sternal border. This is sternum. Suppose this is sternum. So in case of valvular aortic regurgitation, if the problem is in wall, you will find on left mid-sternum. Suppose this is sternum, this is left side, this is right side. You will find on left mid-sternal, okay? And in case of aortic root dilatation, you will find on right upper sternal border, like this one. You will find the sound when you put your stethoscope at this place. It's very important, decrescendo diastolic murmur and S3 may be present. Why? Because there is volume overload. Normally there is two sound, S1 and S2. S2 when mitral tricuspid wall close, and S2 when aortic and pulmonary wall close. But this is S3. This because there is more volume in this. This volume can also produce S3. And there is Austin Flint murmur. This murmur can also, you can also sound this murmur, Austin Flint murmur, on heart apex. Okay, so next thing is laterally placed point of maximal impulse. Why? It's mean your maximal point of impulse. Normally the maximal point of impulse mean when you put in your stethoscope, the point where you feel maximum impulse is normally it is fifth intercostal space in mid clavicular line. Now it is laterally placed. Why? Because heart has enlarged. Suppose normally this is sternum and suppose this is heart. Now heart has displaced toward the lateral side because heart is enlarged due to chronic volume overload. So normally you find apex bit here. Now you will find towards the lateral position. Next is hyperdynamic circulation. Mean when blood coming back aorta into the left ventricle. So during diastole the pressure is less. Why? Because during diastole this wall is not complete and the blood came from aorta into the left ventricle. But when there is systole, the blood also came from left atrium as well as this blood that has came. During systole there is more blood pumps into the body, but during diastole that blood also came. So what happened? There is widened pulse pressure. Mean normally if BP is 120/80, in this case upper is more and lower is less. Suppose 140/60. And the other thing is forceful pulsation in intracranial arteries. The arteries that are present in cranium, you will feel the forceful pulsation. This is called de Musset sign. Systolic pulsation of uvula. This is Muller sign. Pounding sensation in chest. When you see the chest now, you will find there is very pounding sensation. Something is beating like this. This is pounding sensation in chest. There is abrupt distension plus collapse of carotid arteries. The carotid arteries, there would be distension as well as collapse. Why? Suppose this is heart, this put blood into this one. Suppose this is carotid artery. So when there is systole, there is more pressure. During diastole the blood also came back into the aorta, into the left ventricle. So you will find abrupt distension plus immediate collapse. This is called Corrigan sign. And in peripheral arteries, same this phenomena, abrupt distension plus collapsing, is called water hammer pulse. You will also find loud pistol short femoral pulse. When you put your stethoscope on femoral artery, you will feel a sound like pistol shot. This is called Truby sign. On ECG, you will find left ventricular hypertrophy, as left ventricular has hypertrophied. Why? Because there is volume overload. So you will find this sign on ECG. On chest X-ray, you will find left ventricular enlargement. Diagnosis, how will you perform the diagnosis? Diagnosis is based on clinical presentation plus transthoracic echocardiography. Suppose patient present you with these symptoms. He says that I feel shortness of breath whenever I walk to the stair. So you do the physical examination, you find all of this. Plus you have to do echocardiography, transthoracic echocardiography, to confirm the diagnosis. On echocardiography, you will find regurgitant jet from aorta into the left ventricle. When you see, you will find the blood has come back from aorta into the left ventricle. This jet you will find. More than 50% jet mean severe aortic regurgitation. Suppose normally left ventricle pulls blood 100 ml out of into the aorta. Suppose now it's 50 ml of blood is coming back into the left ventricle, 50%. So it means that there is severe aortic regurgitation. You will also find left ventricular dilatation. Now what's the management? For mild to moderate aortic regurgitation, just periodic follow-up. Just came to me in my clinic after 5-6 months. You say to the patient will came to you, and you will just check the left ventricular function. In case of severe asymptomatic, echo after every 6 months. In case of severe, but there is asymptomatic, there is no symptom. In case of severe symptomatic aortic regurgitation, you will do the surgical intervention like wall replacement or something else. Surgical intervention, you have to do it. Medical therapy is limited. Why? Because if wall is damaged, you have to repair it surgically. So its medical therapy is limited.